Hello, welcome to this lecture on the sociology of health and illness. This is really a medical sociology lecture. Medical sociology is the subfield in sociology that studies the institution of medicine and healthcare. Really important these days as we are in the midst of a global pandemic. Healthcare is more important than ever. If you're going on to medical school, sociology is a part of the MCATs since the last couple years. So learning about the sociology of health and illness, learning about medical sociology, especially the social determinants of health, is very important for you if you want to become a doctor or other medical professional. Pharmacy schools, nursing schools, all teach this sort of thing now, some of the sociology of health and illness, as well as various issues relating to social inequalities in health and illness. Which the textbook covers a lot. I'm not going to go into that stuff too much here, but this is a really applicable field in sociology. But before we get started, upon request, I want to tell you a little bit about the final exam in this course. I will send an email out next week or in a week or so with more information about the final exam. I've got to do a little preparation and change it up from previous years because of the different format of this course. But I can tell you that it will be all essay. I will give you a pool of questions, and you will choose some number of questions within that larger pool. So maybe you choose 5 out of 10 or something like that. And I will likely give you extra time to do it. You likely will not be confined to the 2.5 hours on whatever morning your exam is. I will give you a study guide. It'll kind of go over topics that may be asked on the exam, and I may offer a study session, an online study session. Feel free to petition me for more on that, but expect an email in a week or so with more info on the final. Now, back to health and illness. The main concept of this lecture is medicalization. Medicalization. This is, textbook definition, the process by which some behaviors or conditions that were once seen as personal problems are redefined as medical issues. Such medical issues can then become the subjects of study, diagnosis, prevention, or treatment in academia, in public health, in government, and so on. You are familiar with this phenomenon, not in its academic sense, but in sort of an everyday sense at the personal or clinical level. We'll talk later about other levels of medicalization in the meso and macro levels of society. That is how medicalization affects social institutions of healthcare, for example, and how it intersects with social norms and other sorts of things like that. But if you take a look at the pictures that I've gotten at the bottom, well, 2 of which are comics, 1 of which is a meme, and 1 of which on the right, it looks like it's an unfortunate placement. It looks like I'm being birthed by this woman. The one on the right is a documentary on pharmaceuticals for female orgasms to promote normal women's sexuality, much like Viagra for men. This is a documentary on the Viagra, the race for the Viagra for women, right? Because whoever figures that out is going to make a ton of money if they can problematize women's sexuality, just like men's sexual performance has been problematized and medicalized. So that's a good example to start off with. But let's see, on the one on the left is pretty interesting. This comic, this guy's sitting here watching TV, and he says, according to the TV says, at last a cure for whatever illness, and he says, I didn't even realize that was a disease. This is part of the phenomenon of medicalization. Things that we didn't even know were medical conditions are now medical conditions. Like bibliomania. It's an obsession with books, right? That's a thing. I've got my coffee here. You can have all sorts of like caffeine-induced anxiety is in the DSM, the Diagnostic and Statistical Manual. Yeah, that's used for defining, categorizing, classifying, treating psychiatric disorders. So I can have caffeine-induced anxiety disorder, caffeine-induced insomnia. It seems like you just stop drinking caffeine. But nonetheless, that's the point, right? Is that medicalization expands the definition of things that can be wrong with us, and therefore expands the reasons that we need to go seek treatment by professionals, right? We become, and our conditions become the subjects of study, diagnosis, prevention, or treatment. The two middle images, the Ritalin O's and the perception problem, relate to ADHD, attention deficit hyperactivity disorder, right? Or ADD is the old one, but now there's ADHD, which is the more severe kind. But the point of the one on the right is that if you medicalize a problem, it becomes more socially acceptable, right? So like this kid is not lazy. He did not do his homework because he's lazy. He didn't do his homework because he has some sort of like biological or chemical problem with his body, right? He has a syndrome. He has something that's been medicalized. So something that's a personal problem, his laziness, is now seen as a medical condition. He has laziness syndrome. This is wrapped up in the critique of ADHD diagnoses. People who fall on the side of saying that we overdiagnose ADHD may say something like, these diagnoses are often unnecessary because kids naturally have a bunch of energy and are hyper. And so that's sort of an example of that perception problem applied to ADHD. Yeah, so you can look at the DSM, the Diagnostic and Statistical Manual for Psychiatric Disorders, and look at all sorts of other psychiatric problems that have been medicalized over time, right? None of these things used to exist, right? There was no such thing as like a female sexual disorder. There was no such thing as like erectile dysfunction for men and stuff like this until it became medicalized and perceived as a social issue, as a large-scale problem, and then pharmaceutical companies were able to start developing products to treat this new problem. The same sort of thing with ADHD, right? ADHD is really, really new. ADD was sort of formally classified in the 1980s when I was a kid. ADHD came along really in the 1990s, and rates of diagnosis have skyrocketed, and rates of treatment with medications have skyrocketed. So you can see these phenomena happening with lots of different sort of conditions that we have today. Now, medicalization, this phenomenon of a condition that was once seen as a personal issue or a family issue, now seen as a medical issue. Medicalization leads to rising number of types and rates of disability and illness. Why? Well, there are many advances in technology. This seems to be a good thing, right? Advances in neonatal medicine for one. So infants who are born prematurely now can live, right? I have a friend who had a baby at 6 months, I think, very premature. The baby was in the NICU for a long time, and the baby survived. In the very recent past, that baby would have had a significantly higher chance of dying. Go back 50 or 100 years, there's almost no way that baby would have lived. So advances in neonatal medicine lead to not just more surviving infants, but if you're born prematurely at 6 months, you're very, very much more likely to have some sort of disability, cognitive impairment, physical disability, or whatever. And my friend's child does. And so being able to use medical technology and advances in neonatal medicine to allow an infant to survive increases rates of disability, right? Because now someone is alive, but with a disability, when in the past they would have been likely dead. They wouldn't have lived. You can see the same sort of thing in terms of emergency medication, trauma care, and older people. In the past, many more acute conditions and serious accidents and injuries would have led to death. Now they lead more often not to death, but to physical disability or other kinds of disability or injury. And so the person lives, but they have a disability. The aging of the population is a similar sort of thing. Mortality is decreasing for a long time. That is, fewer people in the population die. The rate of people in the population die less than in the past. But the incidence of things that used to kill us is at least the same, and in many cases higher, in some cases lower. So stroke, for example, heart disease. This stuff is more prominent than ever, but it is less likely to kill us, only to disable us. I have here the fourth point down there, longer lifespans of people with disabilities. So medicalization leads to longer lifespans of people with disabilities. There's a great case of Down syndrome, and there are many other cases as well. You can look them up. You can think about which ones might fit this criteria. But the life expectancy of people with Down syndrome has increased from 10 years, right, in about 1960. If you were born with Down syndrome in 1960, you could be expected to live for 10 years. 10! Can you imagine that now? Most people with Down syndrome live far longer than that today. In fact, by 2007, the life expectancy of people with Down syndrome was up to 47 years, and today it's pushing 60. Why? Well, there are lots of reasons for that, particularly the rise of the disability rights movement, visibility of people with disabilities, mainstreaming of people with disabilities in school and work, larger social acceptance of people with disabilities, including and especially Down syndrome, more educational work opportunities, better medical care, advancement of medical technology, and so on and so forth. It used to be that if you were born with Down syndrome, you would just get institutionalized. You might stay at home or be kept at home, not probably allowed to go out into the world, because having any sort of cognitive disability was usually pretty stigmatized. And I'm talking like really recently, right, into the 70s. And there's still stigmatization, but less than in the past. Right, you would have been born with Down syndrome and sent straight to a horrible institution where you would have died on average at 10 years old. Today, you don't get sent to an institution. You're far more integrated into society, and wow, magically, you expect to live far longer because people care about you, right? It's pretty interesting. But that's a function of medicalization. The fifth point, liberalization and expansion of the definition of disability. Like I mentioned on the previous slide, there are more and more psychiatric disorders that you can be diagnosed with. There are more and more things that are classified as disabilities these days. So the simple expansion of categories and the expansion of definitions of categories lead to more people being placed in those categories, right? So medicalization leads to simply more people being captured by more categories and placed under the purview of the medical institution. So lots of reasons why medicalization leads to the rising number and types of rates of disability and illness. Here's part of my Down syndrome example, which is just some more information on Down syndrome. About 1 in 700 babies in the US are born with Down syndrome. Estimates of adolescents or young adults with Down syndrome are about 1 in 1,000 or 1 in 1,200. Interestingly, between 1979 and 2003, the number of babies born with Down syndrome increased 30%. 30%, that's a lot. Part of it is expansion of the definition. Part of it is more visibility and better counting. Part of it is that babies were born and didn't die immediately, or didn't die before they were born, or in some cases weren't killed after they were born. But a huge reason for this is relating back to what we talked about last week with demographic transitions, is an effect of the delay in childbearing years. So the average age at which people have children has increased over the years. I don't know if we've pushed over 30 yet. The last time I looked at this, and I haven't looked recently, it's sort of like high 20s for men and women, a little older for men, a little younger for women, but like in the upper 20s was sort of the average age of having a child in the United States. But that has increased over the last half century from like your early 20s, right? It's increased almost a decade. But the prevalence of Down syndrome, see my graph here from the CDC, the prevalence of Down syndrome by mother's age increases significantly after you hit about 35 years old. So if women or families are delaying having children until women are older, until the mothers are older, the incidence of Down syndrome significantly increases. So to the extent that we continue delaying childbearing years, rates of Down syndrome will continue to increase. And so medicalization and all these other phenomena that are related to that, higher education, better medical technology, and so on, push an increasing rate of people with Down syndrome. So it's pretty interesting. Here's just an example with a visualization of my example of medical technology advancement. So you can see just here on the left is the mortality rate, and on the right is the year. So since 1950, you can just see, especially around the turn of the 1970s, you see the mortality rate just steadily decline, right? And you can see all these particular medical technological advances, whether it's coronary angioplasty being developed in 1979. Don't ask me what that is. The first beta blocker developed in 1962. Open heart procedure in 1954. Let's see. Do I know what any of this stuff means? No, right? Because I just picked a chart that had the point that I wanted to make off Google Images. So you can look at some other examples of medical technology here, but this doesn't mean that mortality rates go down and life expectancy goes up forever, right? People aren't just going to continue living longer, and people aren't going to continue dying less because medical technology continues to advance. Technology continues to advance, but there are a lot of other factors that affect mortality rates. And there are a lot of other factors that affect life expectancy. In fact, in the last few years in the United States, life expectancy has decreased. And this is wild to me. Because you sort of assume that life expectancy has been getting better and better for a long time, and it's going down now? Well, yeah. Now the main reason is because of the pandemic, but we can assume that the pandemic will be over and that influence will correct. Fingers crossed. But the main driver of decreased life expectancy in the United States over the last few years is the increased prevalence of drug overdose, the opioid crisis, that sort of thing. Life expectancy has decreased by about a year on average since 2019 to now. So that's pretty significant. But the point of that is that it's not only about that medicalization. Well, interestingly, in that case, right, if we're talking about overprescription of opioids and things like that, that is a medical problem, and that is part of medicalization. So medicalization actually, in that case, contributes to the decrease in life expectancy, right? More and more people are diagnosed with things. We prescribe more and more medications, so really heavy opioids like OxyContin and stuff like that are available far more easily to a large percentage of the population. This highly addictive stuff. And so the prevalence of this stuff because of medicalization allows people to get easier access to it, increases the risk of becoming addicted to it, and actually in the long term here has caused a decrease in the life expectancy. So medicalization is a double-edged sword, and we will talk more about that in a moment. And finally, medicalization, of course, it makes a lot of money for a lot of people, especially the pharmaceutical industry, right? People love to hate on the pharmaceutical industry. I mean, the pharmaceutical industry is really important. They develop the drugs that save us from all sorts of things. They're developing the COVID vaccines that are hopefully going to be slowing down the pandemic soon once more and more people take these vaccines. Right, so this stuff is really, really important, but as with many things, keep in mind that profit is a huge motive for doing something. Medicalization makes a lot of money, so if you can capture more and more people under these expanded definitions of illnesses, right? Oh no, actually, you have caffeine-induced anxiety disorder. Here's a pill, right? Johnson & Johnson has a pill for caffeine-induced anxiety disorder, right? That is money that you can make off of me because you have classified me as having a problem, a disorder, because of my caffeine addiction or whatever it is. So you can think about analyzing the financial interests of pharmaceutical corporations in medicalization from various theoretical perspectives. So from a functional perspective, I mean, this makes sense, right? They contribute to the stability and the health of a society. This is generally going to be seen as a positive thing. From a conflict theorist perspective, they might think of it as exploitation. So from a conflict theorist perspective, the pharmaceutical companies are expanding categories simply in order to diagnose us more, to sell us more medication, to wring the money out of our pockets, and so on and so forth. So you can, if you're looking at the PowerPoint, you can click through some of these articles here. These are pretty interesting to think about in terms of the financial aspect of medicalization. That first one here says that 84 million adults have prediabetes and 90% of them don't know it. So there's been a real rise in the number of pre-diagnoses in the last decade or so. I was actually diagnosed with pre-diabetes, and when I was diagnosed with pre-diabetes, I wanted to I was mad, right? Like, sort of mad at. I mean, I don't think I'm at risk for having diabetes. Like, I'm in shape. I eat really well. But like whatever. Like there's some diabetes that runs in my family. But anyway, I was encouraged to start taking medication, right, because of my pre-diabetes. It just means I'm at risk for developing diabetes because I fall into some range of blood lipids or whatever. But 84 million adults have pre-diabetes. If you can get pre-diabetes classified as a medical problem and a condition that people need medical attention to fix, that's 84 million adults in the United States. 84 million people is what, like about a quarter of the population of the United States that can be taking some sort of medication, right? A pill that has to buy that pill to help with their pre-diabetes. So these pre-things, again, I mean, I guess it's useful to know if you're like at risk for something, but then labeling being at risk as a separate condition that you need medical treatment for is really can be a dangerous aspect of medicalization that just wraps more people up in the medical institution. The other stuff here is about cochlear implants for deaf people. And this is really interesting. And you kind of need to know something about the deaf community and about disability rights to sort of understand why this matters, like why I'm sort of picking on this example. We have a Sociology of Disability class. I teach it sometimes, and it's a great class. You should take it. It'll open your eyes to all sorts of issues surrounding disability in the United States. But they're essentially, so background here. Many people who are deaf see themselves as part of a community, the deaf community, with a capital D, right? Capital D, deaf community, and they have they're tight. They see the community as having a tight-knit culture, as having a specific culture. They have their own language, right? They use sign language. They have many shared norms and values, and they see themselves largely as sort of under attack by people who think that their deafness is a problem, right? They don't see their deafness as a problem. They see it as a unique part of their identity. They simply communicate differently. They simply experience the world differently. It's not a negative. It's not to the detriment, right? We sort of take for granted that the world is a hearing one, but there are many ways to experience the world. For example, we are actually disadvantaged when things are really loud and we can't hear what someone is saying or what someone is trying to communicate to us, when things are too loud, or when our audio communication is cut off. So if like somebody cuts the phone line, right? There's nothing you can do to communicate with people outside if you can't open windows or whatever. I mean, this is specific examples, but a deaf person, right, can communicate in silence using sign language. And this is a real affordance of being deaf, of knowing sign language. Anyway, there's a huge debate in the deaf community and in disability rights about cochlear implants. Those are implants that go in your ears that allow deaf people to be able to attain some kind of hearing. They can sort of at least recognize voices and things like that. And of course, there's medical technology that makes these cochlear implants. There's a company called Cochlear, and this article you can see here, Cochlear sees profits soar 32%. Right? It's quantifying medical advancements. It's quantifying fixing a problem in terms of profit. Now, this is fine, right? You can argue that it could be useful for someone who is deaf to hear, especially deaf children, and so they can, if they have these implants, they can hear, their whole life. But there's a statement by Cochlear, which is really interesting, and this was like a big debate. And I'll read here down below. Actually, I'll read part of it because my screen's in the way. Provision of cochlear implants for those within the criteria for implantation remains lower in the United States than in some other developed nations. When adults and children are grouped together, the rate of utilization/provision remains low at around 6%. So most people don't have cochlear implants, right? Very few people who are deaf. For children, the provision rate is about 50%, those who could benefit from an implant. So many more children are getting these than adults. They say the reasons for this underprovision include low awareness of the benefits of cochlear implants, something about population, low awareness among healthcare professionals, the lack of specific ways for people to be referred to getting cochlear implants. And then I've highlighted some political issues relating to the deaf community. And that's all that's mentioned of the deaf community in this sort of like sales report from Cochlear, right? They're saying, oh, our profits soared, and our dividends are huge, and we want people to get all these cochlear implants. Well, why? Because they want the money, right? They don't care about the deaf community that doesn't want cochlear implants, that takes pride in being able, in not being able to hear and using their sign language, and having a community around their unique values and norms and lives and their identities as people with disabilities, with people with hearing loss, and so on and so forth. The only time they mention the deaf community is just as an obstacle to making money. So that's my example for, of course, medicalization makes money. And this is a double-edged sword, like I said. It's useful, but it's also problematic. Now, you can think about medicalization as the social control of deviance. Why? Because illness and disability are often seen as deviant things. People with disabilities differ from the norm. They violate norms of how people should look, should think, should talk, and they are often sanctioned for doing so, whether it's individually or institutionally. So think about medicalization in this different sort of way. The increasing number of issues and problems, the increasing number of medical categories that we're placed into, leads to greater control over people, right? It leads to greater control over people, our minds, how we think. Think about medications that you take. If you have ADHD, for example, and you take common ADHD medication, I'm blanking on this, but you know the common ADHD medications. They level you out. They change your cognition. They change the way you think. They change the way you feel. And so there's control in that sense, right? Medications alter your mind, alter your chemicals. Social control over your actions, right? Changing your behaviors, and over your body or even your labor. If you can medicate someone such that they can go to work, right? You're making them good, productive members of industrial society, right? They can work. And this is oftentimes one function of medication, or a reason why people seek medication. They need to be able to work to earn a living. And so medication allows people to fit in, right, to conform to mainstream society, such that they can be in relationships, think normally, act normally, go to work, and just do all the things they're supposed to be doing and fit in. So we'll look at this sort of framework for thinking about medicalization as the social control of deviance. Many conditions have moved over time through the process of medicalization from being perceived as moral issues to legal issues, and then finally to medical issues, right? It's the process of medicalization. Remember, things that move from it used to be like kind of personal issues, perhaps relating to your morality, becoming social or medical issues. So let's take a case. Alcoholism, or alcohol consumption. I've cherry-picked some quotes here from the Bible. You can find quotes like this in all religious texts that caution people against drinking too much, that caution people against oftentimes letting their guard down to the potential intrusion of some negative force, right? So Daniel determined that he would not defile himself with the king's food or with the wine he drank. Envy, drunkenness, orgies, and things like these. I warn you, as I warned before, that those who do such things will not inherit the kingdom of God, right? So don't drink a lot, right? Don't get drunk. You should drink in moderation, I guess, if you're going to drink. Be sober, be on the alert. Your adversary, the devil, is prowling around like a roaring lion, looking for anyone he can devour. So being drunk, right, not being sober, you let your guard down and you become easily influenced right? To do immoral acts or deviant things or be a bad person. So religious texts often point out the dangers of alcohol. You got to keep your body pure. You got to keep your body pure. You got to keep those negative influences out. This is an individual problem, right? It's a personal problem. Like, you need to not drink. You don't defile yourself. You don't engage in drunkenness. You need to be sober and keep your guard up, right? It's a personal treatment, personal problem. What is the treatment for drunkenness? Like way back, and think about way back in the day when the moral sanctions against alcohol consumption were most prominent, was, many years ago. There is no treatment. You need to find religion, right? You need to find God. You need to learn how to get your morals straight. You might have been stigmatized. On the other hand, interestingly, you might have been heralded as some sort of prophet. I'm thinking about the Oracle of Delphi and the Temple of Apollo. It was built upon, I think that the theory goes that it was built upon like some sulfur springs or something like that gave people hallucinations, and the oracle lived there and she had these hallucinations. In her case, it wasn't a moral problem, her hallucinating and her constant intoxication, but rather she was seen as divine. And you can think about shamans and other sorts of religious leaders in other cultures who've taken mushrooms. Read not Don Quixote. Not Don Juan, not Don Quixote. There's some other, I can't think of it. Anyway, think about shamans and people who use drugs or something to commune with God or to commune with higher powers. People who did LSD oftentimes report these sorts of spiritual experiences. And so this can be seen as not a moral thing, but quite a good spiritual thing to be intoxicated. Another example of the moral control of deviance is ADHD. I mentioned that ADHD was really sort of defined and started to be widely applied in the 1990s, ADD in the 80s, ADHD in the 90s, and into the 2000s. But ADHD was actually first mentioned by another name in the early 1900s by a British pediatrician. He described it as, quote, an abnormal defect of moral control in children. And it was called like hyperkinetic disorder or something like that, which essentially means you move too much. Something like that, hyperkinetic disorder. But yeah, he said it was an abnormal defect of moral control in children, right? So it's not that they had some sort of chemical imbalance or anything like medical professionals talk about ADHD today. It's that they couldn't control themselves. They were not good, obedient, quiet, moral children who listened to authority and sat quietly. They moved too much. So that's a really great example. In disability studies, there's a particular model of thinking about disability. It's called the religious moral model, and it fits right in here as well. This model of disability says that disability is essentially a punishment for sin, and also that other sorts of things that are seen as illnesses or abnormalities are sins. So the old idea that homosexuality is a sin, it's not an old idea. Most people don't believe this in the United States anymore, but plenty do. But this older idea is an outcome of the religious moral model of disability and illness. Homosexuality, an act that is deviant, a sexual act that is deviant, is seen as sinful. Schizophrenics were seen as possessed by demons. Mothers who had children with Down syndrome, before people understood the chromosomal causes of Down syndrome, mothers who had children with Down syndrome were seen as promiscuous. Children with disabilities were punished for the sins of their parents, right? So if your child was born with a disability, it was seen as a reflection of the sins of your mother or father, usually mother. And so there are a lot of really great examples of this. But as we move forward into time, as medicalization progresses through the 20th century, as medical science advances, you start to see more emphasis placed on the legal control of deviance. It doesn't mean that the moral control goes away. Rather, the moral control becomes enshrined in law. It's not that there wasn't ever any legal control before, but you start to see this really foregrounded in the 20th century. A great example is Prohibition, right? So from 1920 to 1933, You couldn't make, you couldn't sell, you couldn't drink alcohol in the United States legally. Of course, people found ways to do it, and that's largely where the mafia rose to extreme prominence in Chicago and New York, due to underground alcohol sales and production. So prohibition was an outcome of a moral issue, right? Where you shouldn't drink because it's bad. This enshrines morality into law, and it often targeted, in this case, prohibition often targeted men. So this is seen then as a social problem now. It's not just your personal problem and your lack of good morals that leads you to drink. Now, drinking is seen as a social issue, and so we're going to create a law to prevent people from doing it because we see that it harms the public good. So we're moving beyond the realm of the individual, even the realm of the family, and we realize that alcoholism affects others, affects society as a whole. What is the treatment for the legal problem of drinking? Well, still stigmatized, right? You're still a drunk. But now, more frequently, you're arrested because you violated a law. When something is illegal, it is likely to become deviant and have a social stigma attached to it. So you're arrested. If you're brewing alcohol illegally, your alcohol is destroyed, right? And then finally, the medical institution comes to take over whatever deviant behavior it is, whatever sort of kind of illness it is, if it can define the behavior as an illness, as a disease or illness. So in the 20th century, early on, we start to see an increasing understanding of the medical effects of alcoholism. This is also part of what led to prohibition and its influence with the morality of it and everything. But this newspaper ad on the right, which I will attempt to read to you, is really kind of funny. It's one of these like, gosh, I cannot think of words today. It's one of these like kinds of medicines that like charlatans would sell, right? Snake oil. It says, drunkenness is a disease and can be cured. This is from 1904. It is now a well-known fact to the medical fraternity and to the laity that drunkenness, capital D, is a disease of the entire nervous system, and it is curable, the same as any other malady. We have, our company, at a very great expense, discovered a sure and infallible cure for this curse, having found it by many years of constant study and research. This treatment is not to be compared with the worthless quack cures advertised at so much per package or free. It is a different matter from all this to perfect a course of thorough special treatment that, in all caps, will really lead to the cure, will really do the work and cure forever. This remedy can be given with or without the knowledge of the patient, ethical issues, and can be placed in any food or liquids that the person uses. It is perfectly harmless, because it's probably like water or something. We have and are curing thousands. And we have thousands of grateful testimonial letters on file, speaking of the wonderful cures through the means of this remarkable remedy. We pay $500 for any case that we cannot cure. 87,000 have used our cure during 1902, and we have yet to hear of one that was not perfectly satisfied. So on and so forth. Obviously, this is bullshit, because you can't just cure alcoholism with a pill or whatever they think they had. But with medicalization comes quack cures, right? So you can think about all the bogus stuff that people said that would cure COVID, all the bogus stuff that people said would cure all sorts of stuff, right? Like many people think that you can cure cancer by drinking your own urine. There's all sorts of sketchy stuff out there, or just plain bad or harmful stuff out there that won't cure you, and oftentimes will make you worse, which we'll talk about in a second. But until the medical institution can sort of clearly define the problem and clearly dictate how to treat the problem, then you get a proliferation of sort of quack cures and snake oil salesmen, professing to have the answer to fixing a certain kind of problem. Now, by 1956 in the United States, the American Medical Association had classified alcoholism as an illness. So 1956, all of a sudden, officially, alcoholism becomes a disease. The American Medical Association embarked on a campaign to make this publicly acknowledged and to make it just common knowledge and accepted as fact. By the 1980s and 1990s, the AMA has gotten alcoholism widely accepted as a disease. Alcoholics Anonymous had spread throughout the country, and this has started earlier in the 20th century, but is now a staple in any major city, right? Everybody knows what AA is, and now NA, Narcotics Anonymous, to think about drug addiction as a medical problem. So note the importance here of a medical association, the American Medical Association, as an authority in the process of medicalization and in the process of social control of deviance. Right? Once doctors, once the American Medical Association, once researchers are able to say, this is the definition of the problem, this is the criteria, this is how to diagnose it, this is how to treat it, it's much more able to be accepted. Like, people are much more likely to accept it as a medical condition. You can look at this chart down on the left. This is from a study in 1998 showing attitudes, responses to the question, is alcoholism is it a disease, or is it a reflection of a weakness of an individual? Now, if you think about medicalization, what do you expect? Well, yes, you expect that most people would say alcoholism is a disease, right? It's become medicalized. If it's a weakness, then what is it? We're looking at the moral side, or something individualized about it. Like, your alcoholism is not you being addicted chemically to the drug. It is just you being weak, being immoral. You don't have self-control. People individualize these sorts of things, individualize addictions. Medicalization looks at it as a disease, as something that's less out of someone's control. So interestingly, by profession in 1998, you can see differences in the answer to this. Now, doctors and counselors, people who are in the medical profession, of course, are far more likely to see this as a disease, right? They work with the medical profession. They are the medical institution. Clergy are the least likely to see this as a medical disease, right? Clergy are priests, preachers, right? Religious people, not religious people, but religious leaders. They are most likely to see alcoholism as a personal weakness, right? As a moral problem. And this is still the case today, although the numbers of, most people see it as a disease. And just because something is a disease doesn't mean it can't have a moral element too, right? Those things interplay. Like I said, just because something has been medicalized doesn't mean there's no legal component to it anymore. It doesn't mean there's no moral component to it anymore. It's just the medical part takes over, right, as the dominant mode of explaining it and the dominant mode of social control for it. So you can still jail somebody, right, who gets drunk and does something, who violates open container laws or whatever. But you see the same pattern, okay? So think about this. I'm gonna get this bug. Ah, stupid bug. Some sort of bug's flying around me, but it landed on my screen. It almost got it. Okay, so you can see the same pattern of moral, legal, medicalization as we see with alcohol, with many other things, especially many other things that are considered diseases or illnesses today. Insanity, for example, like schizophrenia, used to be a moral issue, right? The person, like I said, was possessed by demons, was the number one explanation for why somebody, exhibited symptoms of schizophrenia, saw hallucinations, and, was paranoid and stuff like that, right? They clearly, obviously, they were possessed by a demon. Like, what else could it be? Interestingly, the rise of prisons in Europe, throughout the 17th century and around that time, is largely to house people with mental illness. It also housed people who committed crimes, but like the rise of the modern penitentiary was largely a place to put people who had mental illnesses. This oftentimes made prisoners who were in there for committing crimes really afraid, because they were scared and they didn't understand the people with psychiatric disorders. And they very much disliked this. And eventually you get the birth of the mental institution as a separate place. But these people used to go to prison, go to jail. And now schizophrenia and many mental conditions have been medicalized, right? We understand the medical basis of it. We understand the influence of biology and environment on how and when someone develops schizophrenia. And in fact, there's a social movement, part of disability rights, but a social movement to recognize schizophrenia and bipolar disorder and other things, to recognize those as something that shouldn't be stigmatized. It's called mad pride. You can look this up. It's pretty interesting. And the treatment then for a medical condition that we're in the medical mode now, the treatment, well, you can take drugs, you can go to an expert, and you can recover. Hopefully, you can recover. So I think that's a better outcome than, the moral way is just to find religion. The legal way is, well, go to jail and get punished. The medical way is, well, take drugs and you can get better, or you can regulate it. And that to me seems pretty good. And I think that's a really great thing about medicalization. But again, medicalization is a double-edged sword. For every promise of medicalization, there is something negative. So my example here is Iatrogenesis. Say this word with me. Iatrogenesis. This is the idea that sometimes the effects of healthcare or the effects of a treatment are worse than the condition being treated. One outcome of medicalization is increased iatrogenesis throughout society, at various levels of society. So this happens more and more frequently. Old examples are kind of funny. You can think about old examples. And again, you feel like, oh, like these people didn't know anything, like they're so stupid. Well, medical advancements had not really happened much yet. People didn't know that you shouldn't just drain somebody's artery, right? On the left-hand side, this was called bloodletting. You can't just drain somebody's artery and cure them. In fact, they will bleed to death and you will kill them. It's really unfortunate. This is actually how George Washington died from bloodletting. He was sick. I don't remember from what, but his treatment was bloodletting and the man died. Great example of iatrogenesis, right? Death is worse than his flu or whatever he had. Bloodletting, that photo on the left is an 1860 photo of a doctor performing bloodletting on a patient. This idea of bloodletting as a cure was derived from the Greeks. The ancient Greeks thought that everybody had 4 humors in the body, and the humors could be balanced by bloodletting. They didn't understand that blood flows through the body. They didn't understand that the heart pumps the blood through the body. They thought that blood sort of pools in the body. They actually got that idea from observing women's menstruation, right? They thought that women bled once a month because blood pooled in their abdomen, and eventually it got too much and it all came out once a month. That's what they thought. But that's how people used to think about blood in the body, is that it simply pooled. And if you were sick, if you had the flu, for example, maybe that meant you had some like bad blood in your arm or something like that. You had bad blood in your like chest, or you had bad blood up in your head. And depending on where the bad blood was, you had some certain kind of, disease. This is before germ theory and everything, right? And so if you have bad blood, how do you fix it? You drain the blood, you let it out. And normally they wouldn't let all your blood out, but they could let out too much, and sometimes people died. Another one, the middle one here, you can see this person sort of digging around in this other person's skull. This was called trepanning, trepanning, T-R-E-P-A-N-N-I-N-G. And this was the practice of boring a hole into someone's head, drilling a hole into someone's head to release the spirits, right? Oftentimes done for people with symptoms of schizophrenia. If they are possessed by a spirit or controlled by a demon or influenced by a demon, if it lives in their head, just drill a hole in their head. It'll come out. It needs a way out, right? People also used to do this to relieve pressure from headaches, right? The idea was that you had a headache because you have too much pressure in your head, and so if we put a hole in it, some of the air or whatever that's causing the pressure will come out. Obviously, this invasive procedure exposed your brain and led to all sorts of infections, so people often died from trepanning. And the one on the right, you can look and see like what these glasses are. Usually, if I show this to students, they say, "Oh, it looks like urine," or "Oh, it looks like beer." Those are two very different things, and I hope you never get them confused. Don't mistake one for the other and drink it. Drink the urine thinking it's beer. You'll be very displeased. This is mercury. And mercury has long been used as a treatment for many kinds of medical conditions. It's not anymore because modern science, we now know that mercury is highly toxic. You can get mercury poisoning if you're exposed to it too much, and it straight up kills you. But people used to use it as ointment, right? Used to use it for acne. The ancient Chinese used to use it to increase their vitality and lifespan. It was used as a syphilis treatment through the early 20th century. It used to be used as a treatment for constipation. Also, people would swallow lead pellets to treat constipation. Clearly, you just get mercury poisoning and you just get lead poisoning if you do too much and you die. Don't do this. But this is a really recent thing, right? My parents used to tell me stories. They grew up in the 1950s and 60s. They used to tell me stories of playing with mercury as kids. I even played with mercury as a kid a little bit. We used to have it in thermometers. Old thermometers used to have, they were mercury thermometers, and you just break the thermometer open and pour the mercury out. And mercury is really cool. It like pools and makes these little balls, and you can like play with it. But you really, really, really should not touch mercury. And now it is not in thermometers anymore, and you can't get it. You can't touch it. It's highly toxic. So you can think about medical treatments for disease and iatrogenesis, right? How can medical treatments be worse than the conditions that they are treating? Well, a great example that you're all familiar with is these direct-to-consumer marketing commercials, right? Like for Abilify, or for like insomnia, or to treat anxiety or depression or schizophrenia or whatever it is. You see them all the time on TV. Did you know that the United States is one of 2 countries in the world where these kinds of direct marketing commercials are allowed to consumers, right? New Zealand is the other country. In no other country in the world besides the United States and New Zealand are pharmaceutical companies allowed to market their products directly to you. There's pros and cons to this, as with many things. But it's really interesting. This couple here, no doubt they have gonorrhea or something like that, and they've just gone canoeing and cycling, and they're enjoying the best years of their lives, even though they have some STD, or they can't sleep, or their whatever their problem is. But these commercials are fascinating. You should read up on these commercials and the laws of direct-to-consumer marketing and the history of direct-to-consumer marketing. Obviously, the main purpose of this is to allow pharmaceutical companies to reach you, the consumer, and encourage you to tell your doctor that you need this medication, right? With so many things that can be wrong with us, most people are on some sort of medication. Most people think they have something wrong with them, whether they do or not. Well, if the pharmaceutical companies can convince you that you need their drug, well, you are in their pocket and you are giving them money, usually a lot of money, because they never tell you how much it costs in these commercials. Watch one of these commercials. They never tell you the cost. And it's usually a brand name. The commercials are always brand name. They're not going to tell you how much it costs, because it usually costs hundreds or thousands of dollars, right? Way more than the generic, which is often available. And they don't tell you that the generic is available, and they don't tell you how cheap the generic usually is. I'll give you an example in a minute. But they really don't have to tell you shit about the drug, and it's really deceptive. The good thing is you become aware that there are treatments for things. But the many cons here, right? Con is they don't have to tell you hardly anything about the drug. They don't have to tell you how the drug works. They don't have to tell you how many people it benefits or how likely it is to actually benefit you. They don't have to describe the results of their clinical trials. They don't have to tell you the probability of harm or what the harm even could be. They selectively report certain risks, often the most common risks or side effects, with no other context, no other information about what could happen to you, besides just that list of scary things at the end of the commercials, which most people don't really pay attention to anyway. But like if you watch a commercial for an insomnia pill, right, that's supposed to cure insomnia, they're not going to tell you on average how much extra sleep per night people who take it get, right? It could be 15 minutes. You might buy this medication, and on average, people sleep 15 extra minutes a night. I'm not making the number up, right? You can look at the actual drug reports for these medications and see just sort of like how much they help on average. And of course, the insomnia medication is not going to tell you, exactly how likely you might be to be drowsy the next day. They might tell you that a side effect could be drowsiness, but they might not tell you that like 70% of people experience drowsiness. And 5% crash their cars into ditches the next day because they're too drowsy, or whatever it is. They don't tell you about complications with other medications that you may or may not be on. They just say, ask your doctor if it could be right for you, right? Ask your doctor if Abilify could be right for you. So yeah, it puts the ball in your court to be able to advocate for getting these medications, and then it's up to your doctor to recommend you the generic one or to sell you the more expensive one. Yeah, it's pretty interesting. So an example, Abilify. The generic name is let's see if I can say this. Aripiprazole, maybe aripiprazole, but Abilify is the brand name. Abilify is an antipsychotic. It is usually used in the treatment of schizophrenia, bipolar disorder. It's often an add-on in treatments for like major depressive disorder. I think I read that it's been used to treat kids with autism. But well, especially like irritability associated with autism, because it's an antipsychotic, so it sort of like levels people out. But like it levels people out. So again, this is never going to tell you how this works, but what's the word again? Abilify, but aripiprazole is a dopamine agonist, and what that means is it inhibits it mimics dopamine, right? And so it goes into your dopamine receptors and tricks your dopamine receptors into thinking that the Abilify is dopamine. And dopamine it's like a pleasure chemical. It makes you feel good. So essentially what this does is levels you out, makes you feel good. My girlfriend would be really proud of me. She's a pharmacy student, and I've learned about agonists and antagonists. An antagonist blocks a receptor and prevents some chemical from doing its job. So dopamine is an agonist, not dopamine. Abilify or aripiprazole, it's a dopamine agonist. It mimics dopamine, makes you feel good. According to GoodRx.com, which is a prescription coupon company, a 30-day supply of Abilify costs $663. The generic, which the commercial will never tell you about, is $10.99. Drugs.com says Abilify is $940 for a 30-day supply. It ranges anywhere from like the 600s to like over 1,000. And other sites list the generics between like $15 and $30. Now, if you pay the amount of money for the expensive ones, of course, it's a Japanese company that makes Abilify. They make a ton of money from, here's the biggest stat I could find, before their patent ran out. From April 2013 to March 2014, so a span of about a year, sales of Abilify amounted to almost $6.9 billion, billion with a B. So my question for you is there a conflict of interest when conditions become medicalized? Is there a conflict of interest when conditions become medicalized? This is clearly highly profitable. The role of money cannot be discounted, but again, it's a difficult question. It's not simply, pharmaceutical companies are bad. It's far more complicated than that, because they perform many useful services and many useful things. These drugs are very important. People who have schizophrenia are really often helped by Abilify. And so we can like poo-poo the fact that it costs a lot of money and poo-poo these commercials and effectively critique this stuff. But one pro of medicalization is that people who have medical conditions that previously were ignored or untreatable, who previously suffered high levels of serious social stigma because of them, their lives can be significantly improved, right? And that's a lot of people, and that is a really important thing. You can look into this. If you have the PowerPoint, you can follow this, read this article here, America's Love Affair with Prescription Medication. But as an example of medicalization, I said that as categories expand, as definitions expand, more and more people become labeled with medical illnesses and diagnoses that need treatment. In the last 20 years, well now 25 years, the total number of prescriptions filled by Americans, including adults and children, has increased by over 85%, right? It's almost double. That's huge. So we take more medication today than we have ever taken at any time in the past for more different conditions. People of all ages, social classes, racial groups, everyone takes more medications on average than ever before. This article that I've linked, and I don't remember where it's from, but you can follow the article, looks at three main points here. That there is a risk in taking so many drugs. We oftentimes don't think about the interaction effects of drugs. If you're taking 3 different things, the effect of one drug may complicate the function or exacerbate something negative that another drug does. Your doctors don't always know this and are not always aware of interaction effects. There are people whose entire jobs is to tell patients about interaction effects. But the more drugs that are developed, the more complicated this becomes. We also have, just on a chemical level, like we are altered in so many ways the more medications you are on. And I say we, somehow I am not on any medications and never have been on long-term medications, and I aim to keep it that way for as long as I possibly can through trying to practice as good lifestyle habits as I can. But I recognize I'm privileged in this in many ways. But nonetheless, this is something that everyone should think about, trying to minimize the risk, trying to minimize the amount of prescription medications that you are on as much as you can while still maintaining the benefits of those prescription medications. Another issue that this article points out is that there's profit to be made in selling sickness and medicalization. That oftentimes drugs are overprescribed or prescribed when not needed. And this is really the crux of the opioid epidemic, right? That doctors overprescribe serious, strong opioids to people who don't need them. And on the patient side, people often go seeking prescriptions for opioid medications when they do not need them. And the third one I've mentioned already, the rise of pre-disease diagnoses. Iatrogenesis occurs at 3 levels of society, from the micro to the macro. We already talked about the micro a lot, the side effects of medicine on the individual, like all of these, taking Abilify may result in blindness, premature death, blah, 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 whatever, growing a 4th arm. These are side effects of medicine on you, the individual. Social iatrogenesis is the idea that medicalization makes the public more reliant on medical professionals in everyday life. You have more engagement with your doctor probably than anyone has ever had at any time in the past, except perhaps like very rich people who used to have doctors on call or living with them in the past. But in general, we have the ability to see doctors far more. Even people without insurance have the ability to see doctors far more than people did in the past. If you can pay for it, at least. But oftentimes, instead of trying to treat something on our own, we will seek medical attention. You can look at rates of going to the ER. Many people go to the ER when they don't need to go to the ER. This is a problem for all emergency rooms across the country. And educating people about when you actually should go to the ER is something that a lot of hospitals spend a lot of time trying to do. Like, come to the ER for gunshot wounds, if you've been stabbed in the face, if you had a heart attack, right? If you're having a baby, like these are kind of, you need emergency help. But don't go to the ER if you got a paper cut, right? You did something minor, like that people often go to the ER for. And then the third level is on the more macro level, the structural level. Daily life is so heavily medicated that we become unable to cope with natural processes such as birth, illness, and death. This is really interesting. If you think about, which I could ask the class this, right? And I do this in class. How many of you have seen someone die? How many of you have witnessed someone die? There's always a couple, but most people, especially people your age, have not seen anyone die. You may have seen a sick or dying family member, but it is unlikely that you actually witnessed someone dying. that you were actually at their bedside when they died, that they were in your home when they died. Why? Because most people do not die at home. Most people die in either long-term care facilities if you're elderly, or in hospitals. Most people don't die at home. But there's a trend actually toward with increasing rates of people dying at home in old age as hospice care becomes more acceptable and more normal, and this is really great. But because of this, right, because most of us have never actually seen someone die or never actually cared for someone who's dying, we are removed from these natural processes of death. Birth is the same kind of way. Birth used to happen at home. Now birth almost exclusively happens in hospitals or other birthing facilities, not at home like it used to. But this makes us kind of psychologically unprepared to deal with these things. And so you can think about that, the effect that has on these large structural processes in social life. Now, is medicalization all bad, right? Is the systematic medicalization of normality all bad news? Of course not, right? We've identified some positive trends or some benefits of medicalization. You can think about some of these. There are more options for people who have problems. If everyone has some disease or illness, if like we all sort of have something, then disease or illness becomes normal. It's no longer seen as abnormal. It's now seen actually quite normal, typical to have something, to have ADHD, to have general anxiety disorder, to have, to know somebody with Down syndrome, to be depressed or to have depression, either diagnosed or just a more like general form of sadness is more normal these days. We are much more open about talking about mental health these days. There's a huge turn toward this, and that's partly thanks to medicalization. So illness and disability are more normalized and less stigmatized. As more and more people fall into categories of illness and disability, it pushes research to look for solutions to these problems. So it's sort of like a cycle, right? The more that medical science says these problems exist, the more people say they have these problems, the more it pushes medical science to look for solutions to these problems, which benefits people with the problems. It creates a longer lifespan, which, as we talked about in the last lecture last week, has its own set of problems: the aging of society, the graying of the population. But for most individuals, a longer lifespan is a good thing because you get to live longer, especially if you have a longer health span, which is a term that defines the number of quality health years that you have. So your lifespan, like you might live to be 90, but you might only be healthy for 80 of those years, and the last 10 years of your life you might be in really bad health and might not be having a good quality of life. So I have my step grandfather has severe dementia, and his health span probably ran out long ago. He has no idea who he is or where he is or who anybody is. He's very angry all the time. He's no quality of life whatsoever. He's very sad. But he's being kept alive by very good health care and a lot of money, and some people who love him very much. But his quality of life is zero. And it's really sad. So a lifespan and health span are not the same thing, but you can think about the pros and cons of both of those. Medicalization creates jobs. I teach a lot of the courses that I teach in the human development and aging services major. It ties a lot with social work and ties a lot with public health and healthcare. Medicalization is a driver for a lot of jobs for the majors that I teach at GGC, who go into public health, who go into social work, who go into health communication, who go into advocacy, who go into like patient advocacy. And so you can think about others, I am sure. Another thing to think about is demedicalization. This is the opposite of medicalization, the process by which some behaviors or conditions that were once seen as medical issues or problems are now redefined as just a personal thing. I wonder how many of these you can come up with. You think about these. I'm gonna list a couple, but you can think about more. One, probably the best example, is homosexuality. Until recently, until I think 1973, homosexuality was defined as a mental disorder in the DSM, in the Diagnostic and Statistical Manual for Psychiatric Disorders. And so as recently as 50 years ago, less than 50 years ago, you actually medically we're sick, right? And medical science agreed with that you were sick. It has been demedicalized, right? Now same-sex marriage has been legalized, and so the sort of like allowing of people to be openly gay and to marry has become enshrined into law. It's become demedicalized. It's no longer a social problem, no longer seen as an illness. It's now just something personal about you. Another example is poverty, right? Poverty used to be associated almost like as like an illness, right? People used to sort of assume that if you were poor, then you were sick or stupid, or there's something genetic about you that prevented you from achieving, middle or upper middle class success. And that obviously has been demedicalized. There's no treatment for poverty. There's no medical treatment for poverty, although poverty is very closely associated with social determinants of health. Another one is hysteria. Women, just being a woman used to be far more medicalized than it is today. If women expressed the desire to be independent, to work, if they challenged their husbands, if they wanted to vote, if they wanted to do all these things and express independence, throughout much of the 20th century, right? The women's rights movement really doesn't take off until the 60s or 70s, when the civil rights movement is in full swing. In the middle of the last century, it was not uncommon for women to be institutionalized for having depression, for wanting to act, for wanting to go to work, for wanting to be independent, for challenging their husbands. Their husbands would just say, "You have hysteria. You're hysterical, right? You're crazy." It was a particular mental condition afflicting women, but that is no longer the case, right? We recognize that this is simply sexism at work. And hysteria has been demedicalized. There's no such thing as hysteria. So some examples. Finally, you can watch this if you are not coming to class this week. If you are coming to class this week, I want to watch this in class. I love this video so much. But this sort of ties together a lot of what we talked about last week and a lot of what we talked about this week. Ties together a lot of stuff on population and demographics with stuff on health and patterns of health in societies. Think about not just health in the United States, but also health in other countries. Think about how globalization has affected the lifespan of people in different countries, how globalization has affected healthcare in different countries in comparison to one another. How have these countries' movements been shaped by the things that we've been talking about recently? Medicalization today, fertility rates and aging of the population last week. I'll leave you with these thoughts, and hope that you find this discussion, have found this discussion of medicalization and iatrogenesis really interesting. This is super interesting stuff to me, and I'm going to try and sell you on the sociology minor and the human development major if you're interested in this stuff. You can look into it more at GDC. We also do have a health sciences major that's new in the fall. So now I'm talking you out of our major and telling you to go to health sciences. But the human development major touches on a lot of this stuff and really teaches people how to work with populations and take into consideration social determinants of health to improve health outcomes and quality of life for people. But we have courses like the Sociology of Disability, where you look at the social construction of disability, you look at health outcomes with people with disabilities, you look at the history of the disability rights movement. I teach a class called Death, Grief, and Dying, which is on offer next semester. I teach it every fall. And it's on how society thinks about issues relating to death. We look at the death industry, so we look at like the funeral home industry, and everything related to the death industry. We look at media coverage of death. We look at our social attitudes toward death. We look kind of psychologically at how we grieve and cope with loss, not just of death, but of any kind of loss. It could be like moving and the loss of your home, or the death of a pet, or something like that. We look at death cross-culturally, right? How do different cultures understand death? What happens to people after they die? We look at all sorts of conceptions of the afterlife and what people think about souls and spirits and all sorts of cool stuff like that. It's a fantastic class, very challenging. very emotionally draining, I think, but a really, really good class if you're interested in that sort of stuff. So I will leave you there. I hope you have a great rest of your week, and I will see some of you this week in class. Bye.